I am Dr. Zeev Rosberger. I am a senior investigator at the Lady Davis Institute for Medical Research at the Jewish General Hospital in Montreal and associate professor at McGill University in medicine and psychology. My interest was in how do parents make decisions about giving the vaccine to their children? What is public policy about giving the vaccine? How do we inform parents? Through a whole series of events, political, economic, and so forth, vaccine programs were initiated for free across Canada. It took about 10 years. We started doing research about 10, 12 years ago looking at acceptability and uptake. What do parents know? What are their attitudes? What are their concerns? There was a lot of stuff out there. The anti-vaxxer movement in general had an impact on this because there are side effects, but virtually none to the vaccine. But there are stories that happen. And if you give millions and millions of doses of a vaccine, invariably, just by chance, there will be things that happen after you give a vaccine. And people say, well, you know, it causes this, it causes that. The evidence shows over a large number of years that there are no significant side effects to the vaccine, short or long term. So these are all individual issues, and as a psychologist, I'm interested in how individuals make decisions, but by the same token, we want to know how populations react to this, how policy influences this. So we've done surveys over a number of years looking at attitudes, beliefs, and knowledge of parents, how they make decisions, what stage they are, what do they know, what do they not know. We've also, from the data that we've collected, taken an interest in advocacy and in issues of ethical issues such as equity, and gender-neutral vaccination. Why are only girls getting it as opposed to boys who are part of the problem in terms of transmission? And so we've been involved and engaged in that, and we've written some papers. I wrote a paper a few years ago for Psychosocial Oncology, for the Psycho-Oncology Journal, on cancer prevention in the field of psycho-oncology. And I really felt that this was neglected by us in the field. We've spent a lot of time in the early years, past 30 years or so, looking at the impact of diagnosis, the impact of treatment, the impact of end-of-life survivorship, and so forth. But we really didn't look at the pre-diagnostic phase, the population-based phase. And I think as a psychologist, understanding how individuals make decisions is a way of learning how to intervene and also to develop messaging to appropriate populations so that they understand what are the benefits of vaccinating children, their children. Just like measles, mumps, rubella is pretty routine everywhere in the world. Of course, it's very cheap. The HPV vaccines are much more expensive for a whole host of reasons, but the governments have come through, particularly in Canada and in other areas of the developing world. And I think we've had an impact as psychologists and psychosocial oncology specialists because we recognize that intervening at an earlier stage in a preventive model, just like exercise, for example, is another important prevention. Diet, we know, has an impact. So all of these factors are factors that are lifestyle, decision-making issues and require intervention. And as psychologists, as understanding how people make decisions, can allow us to message appropriately, not just for cancer prevention, but for disease prevention in general. The work that we're doing now is looking at screening. So in addition to vaccination, which is a tremendous public health improvement, bringing vaccines to the developing world is a major issue. So that's a public policy and a financial issue. But we have an important role to support that, where the prevalence of these diseases is much higher. And we're also moving away from PAP screening because the technology has been developed in recent years to very rapidly assess swabs, vaginal swabs, for example, for cervical cancer. Instead of looking under a microscope and doing PAP and seeing if there's lesions there, precancerous lesions, you can actually test for the HPV DNA. Having the HPV DNA there doesn't mean you have cervical cancer or precancerous lesion, but it tells you something about what's going on, and while there's no real prevention of that, monitoring is important because it could become a lesion. So guidelines have changed. Primary HPV screening, as opposed to PAP. PAP is being phased out. Primary HPV screening is coming. It started in Australia. It's going to start, I think, this year or next year in the UK. And there are plans in progress to introduce primary screening in public health for cervical cancer, for HPV in Canada. But because each province does their own thing, each province is at a different stage. So there aren't any programs yet. The message to my colleagues is, maybe there's a place for you. There is research ongoing. Maybe there's a place for you to bring the knowledge that we have of working with patients to the primary prevention sphere, which is ahead of the game, so that patients don't get diagnosed with cancer. Or if they do, maybe later on, or with diseases that are more treatable, easily treatable, and so forth. I give just as one example, oropharyngeal cancer that's caused by HPV is largely curable. I mean, there have been some studies to show that even if you get a throat cancer that's HPV related, chemo and radiation will virtually cure it. Not without side effects, not without problems and so on, but if we can get to the earlier stage, and we know that maybe oral sex is the way of transmitting that to the throat. We don't even know that that's the case, but we can suspect that it is. Then maybe there needs to be some preventative measures in terms of sexual behavior as well. But, safe sex is good sex no matter what, particularly in HPV transmission.